Hi guys, so this is a continuation of our lecture. I'm just going to start all over from cocci. So coccidioidomycosis or valley fever. So again, as mentioned earlier in class, this is a fungal infection and the primary site is in the lungs. But that being said, it can actually spread beyond the lungs. So it can have a disseminated form wherein it is basically spread everywhere, and you'll see it also in the skin, internal organs, bones, meninges, and skin. Anyway, I repeat it again. So anyhow, how does a person get cocci or valley fever? So this is basically from the soil. So the fungus lives in the soil. It is more prevalent in areas like ours, right? Like Kern County, because we're in a valley. Basically, we have all this dust and soil. And so we are at a high risk of developing or getting cocci. Symptoms of cocci, as mentioned to you guys earlier, so generally speaking, the symptoms are going to be very similar with your typical pneumonia or a cold, because then patients tend to present with fever, aching, chills, sweats, fatigue, cough, and headache. That being said, for most people, what happens is they start them on antibiotics, or maybe sometimes they're just waiting for the illness to pass. But then, then it's not getting better. So that's when they start thinking about maybe there's something else causing the patient's symptoms. One thing, though, it's a little bit more indicative of valley fever is this lesions on the extremities or lower extremities. They look like bruises. They can be painful. They are called nodular erythema. So this can be seen in patients with valley fever. So the severity of symptoms depend on how much of the fungus or how much spores they've inhaled, and also their susceptibility to infection. So a patient who is immunocompromised will probably have more severe symptoms than a patient who is typically healthy and does not have any other comorbidities. So examples of this would be a patient receiving chemo, a patient with autoimmune disease. So again, patients who are whose immune system are more compromised, they will tend to have more severe symptoms, and typically it is a lot harder to treat their fungal infection. So diagnosis, how do we diagnose for valley fever? We have, as mentioned in class, skin test. So basically this test is more for testing of history, but it's really not helpful in diagnosing current infection because this can still turn positive from a previous infection. Also, take note that about 30 to 60% of people in high endemic areas such as Bakersfield may test positive for having had the disease. So again, it doesn't mean that the patient currently has the disease just because they're positive on this test. Now, you may also have cocci titers, which is a blood test wherein they measure the concentration or amount of antibodies present in the blood. So this is more sensitive, and the higher the titer, it means that the disease is more severe. Also take note though that as the immunity develops, as the longer they have the infection, you may see a fall or decline in titer levels. As many other illnesses, if we don't really treat it right away, or maybe if it doesn't get better, it can lead to complications. So some complications include pleural effusion. So what is pleural effusion? This is basically fluid buildup in the lungs. Now, there can be a relapse of infection. So sometimes you already treated the valley fever, but it can reoccur. And sometimes for certain patients, whenever it happens all over again, sometimes it can be more severe than the previous one. In addition to that, as mentioned earlier, this can spread to different organs, so to the rest of the body, and it can become disseminated. Some patients will also experience complications from the treatment themselves, so from the medication, especially liver and kidney, because most of these antifungal drugs can actually affect the liver, and then there's a very specific one that can affect both the liver and the kidneys. And one thing that's not in your list that I added is pneumothorax. So that's a potential complication. I've been noticing that at least for this semester, whenever we're caring for patients with valley fever, a good amount or good number of them have developed pneumothorax. So pneumothorax is basically a collapsed lung. And that's usually secondary to the damage that the infection has caused. So it just makes the stability of the lung, basically it diminishes its stability. So it increases the risk for developing a collapsed lung or pneumothorax. All right, let's talk about the pharmacological treatment. So what medications do we give to patients with valley fever or cocci? So for non-life-threatening disease, so for patients who maybe don't have any other comorbidities, they're not as symptomatic, we can give them oral antifungals, and examples of this are ketoconazole oral, fluconazole oral, and itraconazole oral. Now, in severe cases or when a patient has a disseminated disease, then we give them amphotericin B IV or intraspinal. So as mentioned earlier, this can spread in the spine. At the same time, you may have some patients who may need to also be on fluconazole or miconazole. So these are IV medications. So in disseminated forms or severe forms, patients tend to need IV antifungals. So these are a lot stronger. Take note that because they're a lot stronger, there's a tendency to have more side effects, especially your amphotericin B. So amphotericin B is given to patients with severe diseases or disseminated version of the disease. Take note that with these patients, if they're receiving ampho or amphotericin B, they actually have to monitor their liver and renal function. So both hepatic and renal function, they have to monitor it and trend it, because you may see a spike of their liver function test as well as their renal function test. Now, because of the known side effects, so amphotericin B can actually cause so many side effects, which includes joint pains, hyperthermia, nausea, vomiting. So patients can get pretty sick from getting amphotericin B. And so when a patient is already on it, like if it's ordered for them, usually they will pre-medicate the patient before giving the medication. And common medications that they use to pre-medicate patients who are about to receive amphotericin B include diphenhydramine, which is Benadryl. They may give them steroids, acetaminophen, ibuprofen, fluids. I've seen patients receiving fluid before administration of amphotericin B and after administration, so they just give them fluid bolus to help kind of flush and help with those symptoms and help hydrate the patient. In addition to that, as mentioned earlier, this medication can cause severe nausea and vomiting. So sometimes they may start patients on antiemetic even before the patient starts complaining of nausea or vomiting, just because they're already anticipating for the side effects. So please know this. This may be on test. And as you notice here, I also emphasize here LFT. So generally speaking, if your patients are on antifungals, look at the kidney functions. Look at the liver functions. The kidneys can be affected, but in these specific types of medication, we need to keep a close eye on the LFTs because it can really go up significantly. Now let's talk about obstructive sleep apnea or OSA. Obstructive sleep apnea, from the name itself, is basically an obstruction of the airway that happens during sleep. So there are risk factors for that. It is more common in male. Obesity is a big risk factor. Patients who smoke, who drink, and patients who are 40 to 65 years old, menopausal women, patients who have nocturnal dysrhythmias, type 2 diabetes, heart failure, pulmonary hypertension, and also patients, even though they don't have all those comorbidities or issues, some patients who just have a different anatomical variation of their airway, tongue, tonsils, the uvula, and all those things. So those are risk factors for developing obstructive sleep apnea. So some clinical manifestations, so signs and symptoms or cues that we're looking for if a patient has obstructive sleep apnea include loud snoring, snorting, gasping during sleep, recurrent waking during sleep, and then feeling of choking or even waking up choking. And then whenever they wake up, these patients tend to be tired regardless of the amount of sleep that they get. Some patients complain of morning headaches, and as mentioned to you guys in class, hypertension. As I said before, some patients who have hypertension, and let's say they're really difficult to treat, we've given them so many antihypertensive medications, yet their blood pressure doesn't go down. Sometimes what we do, especially when I was practicing as a nurse practitioner, is that I basically send them for a sleep study, especially if they have maybe other risk factors, maybe if they're a little bit more bigger or obese, then I would send them for a sleep study. And most of the time, once we fix or we treat the obstructive sleep apnea, their blood pressure actually improves, some with less medications than what we started with, or some of them, they won't even need to be on antihypertensive once the sleep apnea is taken care of. So again, sleep apnea can actually influence the patient's blood pressure. Now, how do we diagnose sleep apnea? So sleep apnea is diagnosed with sleep studies. So what they do is that they put a patient on a monitor and they basically watch the patient sleep, monitor everything as they sleep, and really count the times that they're apneic or they're not breathing. So whenever a patient has 15 or more instances wherein they have an event of obstructive sleep per hour, then that may be considered a sleep apnea. How do we treat it? So treatment, really, it's not that we can cure it. Well, we can fix certain things depending on the cause, but generally speaking, patients with obstructive sleep apnea will need to be on continuous positive airway pressure, or CPAP. So CPAP actually blows air, right? Administers airflow to create the pressure to keep their airway from collapsing. So it's continuous, and in contrast to your BiPAP, the BiPAP have different pressure levels on inspiration and expiration. Meanwhile, CPAP will just have a continuous, basically same pressure going on continuously from the name itself, right? Other ways to treat sleep apnea is definitely, especially if it's if a person is obese, then that would be weight management. And for some people, especially people with anatomic variations, then they may need to have surgical management. So that can include tonsillectomy, adenoidectomy, septoplasty, and tongue reduction, especially, again, those people who may have really large tonsils that maybe they're okay when they're upright, but once they lay down, right, those tonsils, right, because of gravity, may start obstructing the airway. Same goes with the tongue and so on. So those could be ways to manage or treat sleep apnea. So what are our nursing intervention? Again, assessment. Also, when we're gathering their history, ask for their sleep, the amount, how they feel after they wake up. Do they feel rested? Vital signs. Make sure not only we're worrying about your respiratory status, right, your respiratory rate and oxygen saturation, but because, as we mentioned earlier, sleep apnea can manifest as hypertension. So we need to check the blood pressure. Any signs and symptoms of respiratory distress post-operatively. Now, what do we do for this patient? As we mentioned, CPAP, right? If they need to be on oxygen, especially while they're asleep, we may need to put them on oxygen. They may need to be on antihypertensive medication until we treat or we manage the sleep apnea. And then teaching wise, so we need to teach them about the disease process, the medications that they're going to be on, the purpose, side effects of the medication. Maybe it's a person that's going to be on CPAP, so we have to teach them about how to use it, when to use it. And I know some of these patients are going to say, well, I feel better now, I won't need it anymore. Really, like with any other treatment, most of these treatments will need to be continued, and the reason why they're feeling better is likely because they're using it. So when they stop using it, they may start having the same symptoms. One big factor, especially for obese people, would be weight reduction, because again, that can actually cause or worsen sleep apnea. And we can also collaborate with the RT. Usually in the hospital, they're the ones setting up the CPAP machines. All right, our problem list for sleep apnea include risk for hypoxia, risk for decreased cardiac output related to hypoxia, sleep deprivation, ineffective sleeping pattern, risk for injury, and anxiety. Alright, some NCLEX questions. A client's blood oxygen saturation level is at 99% on room air. The nurse realizes that the oxygenated blood is transported to the heart through which of the following structures? A. Pulmonary arteries, B. Pulmonary veins, C. Bronchial arteries, D. Bronchial veins. The answer is pulmonary veins. Right? So this will bring back the blood to the heart. Next question. A client who was diagnosed with COPD has a pulse oximeter reading of 82% on room air. A nurse should obtain an MD order to do which of the following interventions? A. Provide high volume O2. B. Intubate. C. Provide an oral airway. D. Administer low volume O2 and monitor respirations. The answer to that is D. Administer low volume oxygen and monitor respiration. And as the rationale for this is, as we mentioned earlier, we have to be very careful with COPD patients, because if we give them too much oxygen, it may actually stop them from breathing, right? Their respiratory rate will go down because their respiratory drive will go down, because they're already getting the oxygen that they need since they're so used to high CO2 levels. Now, providing high volume of oxygen is actually contraindicated to COPD patients who are not in respiratory distress. Intubation is a little bit too extreme, right? It's really not necessary for that. And same thing as provide an oral airway. That's too invasive. Again, COPD patients may be okay with just starting 87-88%. Another NCLEX question. What must a nurse determine before terminating airborne precaution for a client with pulmonary TB? A. Mantoux skin test is negative, or the PPD skin test is negative. B. Client is no longer coughing. C. Sputum is free of acid-fast bacilli 3 times. D. Client's temperature has returned to normal. So the answer to that would be C. Sputum is free of acid-fast bacilli. The negative PPD is not really indicative that the patient does not have it anymore. Also, the not having any cough is not a guarantee, as well as the temperature being back to normal. So the answer is C. Sputum is free of acid-fast bacilli 3 times. And that's usually what we do in the clinical setting as well. Alright, let's talk about pulmonary tuberculosis pathophysiology, or tuberculosis or TB pathophysiology. So this is basically a lung infection caused by Mycobacterium tuberculosis. It is an acid-fast bacillus. It's gram-positive. And so the thing with this type of organism, the droplets can remain in the air for several hours, and so somebody can actually transmit it that way. So somebody can actually acquire it through the air. So hence we put our patients in airborne isolation. Now, the bacteria will be commonly found in the lungs. That being said, you can also have tuberculosis in different parts of the body. Now, the transmission is through airborne droplets. Some patients can develop a latent TB, so this is when a granuloma forms and encapsulates and surrounds the infected area, so it will limit the further spreading or proliferation of the bacteria, and so it keeps it in place. And the problem with that is it causes necrosis or tissue death in the center of the granuloma, which then can cause scarring or fibrosis and calcification of that part of the lung. And sometimes really that's what you see when you see cavitations on x-rays. You guys can watch this video over here, so there's a link here. Feel free to watch it to give you more information about tuberculosis, etiology, incidence, and prevalence. So again, this is airborne, right? Transmitted through airborne. Most patients will acquire this through close contact with another infected person. So unfortunately, the number of patients with tuberculosis has been increasing in the US and worldwide. Who are at risk for developing tuberculosis? Well, one, the patients with immune dysfunction, or the patients who are immunocompromised, which include the diabetic patients or patients with HIV. Also, people who live in crowded areas, such as your prisoners and patients or residents that live in a skilled nursing facility. Older people, also foreign-born people from countries that have high prevalence of TB. So example would be the Philippines. Other people who are at a higher risk include homeless people, people with drug and alcohol abuse. Also, patients or people in a lower socioeconomic group, and us, healthcare workers. That's the reason why a requirement for you guys in the nursing program to go to your different rotation is to get TB tested and have a N95 mask fit test, because we're at a high risk for developing TB. And that's just because we see so many patients, and by the time we find out if, the patient has TB or not, we've probably already been exposed. So we are at risk for developing it as well, even if we're not immunocompromised. All right, droplet nuclei transmission. So this is really a term to describe how sometimes when a person coughs, there's the wet part of the cough, right? But because the force is so strong, it breaks it down to little particles, and some of those particles are actually more on the drier side rather than wet, and those can actually stay suspended in the air and cause the bacteria or microorganism to be spread quicker. There are 3,000 droplet nuclei spread, so in one cough, and in 1 minute of singing, and then in 5 minutes of talking. So can you imagine, right? And sometimes we don't even know if the patient that we're talking to have TB or not. So just something to really think about and know. And that's why we tell our patients, right? Even if we don't know yet what they have, make sure you're covering when you're coughing. Not only our patient, even other people, right? Because we just don't know. They may be transmitting all these microorganisms in the air. All right, so what are the cues? So what are the signs and symptoms of TB? So when we're assessing our patients, these are the common clinical manifestations or cues. So this is what we want you to put in your concept map. So if you have a patient with tuberculosis, this should be in your clinical manifestations or cues or signs and symptoms. So they're basically the same thing, right? Anyhow, shortness of breath. Because again, the primary organ that's affected in TB are your lungs. So patients can complain of shortness of breath. They may have some wheezing, frequent coughing. Sometimes it can be non-productive, and when it is productive, it usually is blood tinged or has like a pink frothy sputum. Patients may complain of night sweats and anorexia or weight loss. Some patients may have some nausea. Other patients will have fever and chills, fatigue, and lethargy. So again, on this illustration, maybe this will help you remember it better if you look to your right. These are the main symptoms of pulmonary tuberculosis. So in your central nervous system, patients will have generalized weakness, weight loss, fever, loss of appetite. In the lungs, you will notice some coughing, pleurisy. So pleurisy is basically a sharp pain felt in the chest when breathing in deeply or coughing. And then they can cough up sputum, and sometimes with that sputum you may see some blood, and they may complain of shortness of breath. Skin-wise, patients with TB may have night sweats. So diagnostics, how do we diagnose a patient with tuberculosis? We can do a culture or mycobacterial culture, and this will have the highest sensitivity. So this is more accurate in identifying those who have the disease. So it means that most likely, right, if the culture is positive, it is highly likely that the patient has the disease, so has tuberculosis. So if their culture result is positive. Usually we use the AFB test, and this is less expensive, And the problem with this, it's not very specific and it's not very sensitive to TB because there are other organisms that can be AFB positive, because again, there are other bacteria that can be AFB positive. Now, the sputum culture is gonna be your main test to confirm TB, but it's not the AFB test. AFB test is different from sputum culture. That's why I crossed it out, because I don't want you guys to get confused. So sputum culture, that's the test to really confirm, right? The mycobacterial culture, that will be the one that will help us confirm that the patient has the disease. AFB alone will not. Anyhow, another test that we do, and we use it more for screening purposes, would be your tuberculin skin test or TB skin test. So again, this is a preliminary diagnosis. So usually what happens, they get tested. If they are positive using the skin test, there's usually additional testing that needs to be done to confirm the diagnosis. So additional testing can include a chest x-ray, and then sometimes in addition to a chest x-ray, they may have to send out sputum cultures. You also have a blood test to check for TB. So the blood test or gold quantiferin, that's really another alternative that we may need to do. Let's say we're trying to just screen for TB, and for some reason a patient has a reaction to the tuberculin skin test, then these patients may qualify to be tested using the quantiferin gold. So this doesn't really have the highest sensitivity, right? It doesn't really accurately say, hey, the patient currently has the disease, but this is more specific. This is more specific because it is more accurate in identifying those without the disease, meaning that if your gold quantiferin is negative, you likely don't have the disease. Chest x-ray, usually again, it's just an additional test that they will order depending on the patient's symptoms, and sometimes if the patient is positive for their skin test, this can help the provider identify if the patient has an active or maybe a healed tuberculosis. Alright, so what are our interventions? So our TB patients, they are on airborne precautions. So as soon as, even if it's a rule out TB, if a patient is basically admitted and they are not 100% sure yet that the patient has TB, even though it's still a rule out, we still need to isolate the patient, because guess what? If we don't do that while waiting for all those test results, right? If we don't isolate the patient, and maybe if we find out 3 days later that the patient is actually positive, guess how many people we've already exposed to TB? And not only that, what if we're in a hospital where they have a shared room, right? We may end up exposing another patient. So again, even if it's not confirmed, if there's any sort of suspicion that the patient has TB, they need to be on airborne isolation. So they need to be in a private room that has negative air pressure, and then we will need to wear a HEPA mask. So this is a high efficiency particulate air. Example of that is your N95, and then we need to wear our gown and gloves if there's a possible risk of maybe a contamination of our hands or clothing. Now, we need to, again, this is a respiratory issue, right? It's mainly affecting your lungs. So therefore, we need to monitor the patient's respiratory status. So we need to do a good job at assessing our patient's respiratory system. We monitor our oxygen saturation, and if needed, if the patient is desaturating, we may need to provide supplemental O2. Now, these patients, they tend to lose weight. For one reason or another, the infection can really affect their weight. Sometimes just the disease alone, just the constant coughing can cause the patient to lose weight, and their appetite will go down. So most of these TB patients, they tend to have a significant amount of weight loss prior to diagnosis. So knowing that, we need to make sure that we're providing the patients with diet that's rich in protein, iron, and vitamin C. In addition, we need to obtain sputum culture every 2 to 4 weeks. And after 3 negative cultures, the patient is no longer infectious. Now, also, it is very important that we administer the prescribed medications. And if we have to send them home with these medications, or they have to stay at home, we need to make sure that they're actually taking it. So what are the medications that we use to treat tuberculosis or TB? So currently, we use INH or isoniazid and rifampin throughout the therapy. So just remember though, isoniazid can cause neuropathy. And so if we know that a patient is receiving INH, we need to make sure that they're also on vitamin B6. So that will help with the neuropathy if a patient is on INH. Something to know about or remember about rifampin is that it can change the urine color into like a bright orangey color. Also, another medication that we may see with this is the pyrazinamide, which is usually added for the first 2 months. Some other medications include ethambutol or streptomycin, which can be added as the 4th drug. So having all these 4 medication will allow for shortened therapy from 6 to 12 months to just 6 months. So we need to make sure that they are compliant with medications. Now, a streptomycin tend to be added if the infection is extensive, or maybe if we have issues with non-compliance, because at least it shortens the duration of the treatment. Speaking of compliance issues, so the treatment again is long, so it's 6 to 12 months, and they have to be very consistent. Now, successful treatment of TB is really dependent on the patient's compliance, and if they're already home, it's really hard for us to know if they're taking the medications. So sometimes if a patient is known to be non-compliant, they may send a nurse or somebody from the public health department to really ensure that the patient, right, that they actually visually see the patient taking the medication. The failure of a patient to take the medication is the most important cause of failure to cure the TB infection. And not only that, if we're not curing it, right, and some of these patients do, not only they're not taking their medication, but they will start going out and really socializing with other people, and they're really putting other people at risk. And so that's why it is very important for these patients to be compliant. Some patients can have or develop drug-resistant forms of TB. So this is a TB version that does not respond to drug treatment. So it has become a very serious problem in the recent years. And again, sometimes this is really secondary to non-compliance. They may start some treatments and they don't complete the course. So again, what doesn't kill you will make you stronger, and that applies to your Mycobacterium tuberculosis. So if we don't really eradicate them, they may become resistant. So we have to be very careful with that. Just FYI, your first line of treatment for TB will be your isoniazid, rifampin, pyrazinamide, and ethambutol. Second line includes streptomycin and other drugs such as amikacin, levofloxacin, and moxifloxacin. Alright, so speaking of resistance, so there's the so-called XDR-TB, or extensively drug-resistant tuberculosis. So this is the type of tuberculosis infection that's resistant to both first line and second line of drugs. So these are resistant to any fluoroquinolone and at least one of the 3 injectable second line drugs. So when a patient is diagnosed with this, we're actually very limited. It's going to be very hard to treat, right? Because it doesn't matter how strong the medications are, these are just extensively so resistant that, again, we won't really have a lot of options at that point. All right, let's see here, nursing intervention. So patient education, as you guys know, patient education is very important for this type of patients, right? Especially when we're talking about compliance. Also, infection control, making sure that they're washing their hands. If they're coughing or sneezing, making sure they're covering that and disposing, right, of the tissue that they've used accordingly, not just leaving it, anywhere, or maybe touching everything with it and using it to wipe the table. That's gross. Anyway, make sure that there's adequate air ventilation in the room. Again, we don't want a very closed area, and then everyone else is inhaling that same air with all the mycobacterium floating, right? Another thing is make sure that they're taking their medications as prescribed for the full duration to prevent resistance. So for some patients, like I told you guys, who are non-compliant, they may need direct observation therapy or DOT. So if you see this, it means direct observation therapy. And that is really when they send somebody to literally, visually see the patient as they're taking that medication just to ensure that they take it. Another thing that we need to tell our patients is that they need to make sure that they're still eating, maintaining adequate nutrition, because that's really just going to help with their immune system to hopefully fight the infection a little better, especially because we know that TB patients tend to lose weight, their appetite is down, and they may develop muscle wasting. Resting is going to be very important to heal and at the same time to prevent fatigue. This link right here, you're going to have it on Canvas. You can press on it. That would be your link to the Kahoot that we had in class. All right, I'll see you guys next week.